everyone, and welcome to today's PHO Rounds presentation, Can a Voluntary Isolation Centre Reduce Secondary Transmission of SARS-CoV-2 in Households? A Matched Cohort Study. My name is Leanne McDonald. I am the Public Health Physician Lead in Communicable Disease Control at Public Health Ontario, and it's my pleasure to be moderating today's session. I want to begin with a land acknowledgement, with thanks to my former colleague Daniel Clare Coles. We acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. We acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. We acknowledge and respect the traditional territories and communities of the Métis Nation of Ontario. We acknowledge and respect Inuit connection and contribution across these lands and waters. Please join us in acknowledgement and respect of all Indigenous peoples. So it's now my great pleasure to introduce our speakers for today, Jocelyn Edwards and Dr. Kevin Brown. Jocelyn Edwards is a program evaluator at Toronto Public Health, assessing public health programs to enhance effectiveness and client experience. Her work has shaped evaluation frameworks adopted across Ontario during the COVID-19 pandemic. A member of the Ontario Public Health Evaluation Network, she's also a recipient of the Kristen Beacon Achievement Award for Leadership in Public Health Evaluation. Welcome, Jocelyn Edwards. Dr. Kevin Brown is an infectious disease epidemiologist and scientist at Public Health Ontario, as well as an associate professor at the University of Toronto. He holds a PhD in epidemiology from the University of Toronto, a master's in public health and biostatistics from the University of North Carolina at Chapel Hill as well. His research focuses on modeling infectious diseases, including C. difficile, antimicrobial resistance, and SARS-CoV-2. And with that, I'll pass it over to Jocelyn. Thank you.
Great, thank you so much. Hello, everyone. As Leanne mentioned, I'm Jocelyn Edwards, Program Evaluator with Toronto Public Health, and I'm joined today by Dr. Kevin Brown, a Senior Scientist at Public Health Ontario. Here we are. The information that Kevin and I are presenting today is based on a published manuscript crafted by an amazing project team composed of staff from both Toronto Public Health and Public Health Ontario. And before proceeding, I want to acknowledge their enormous contributions to the manuscript and the presentation. In clinical infectious diseases is where you can find our published manuscript. We set 3 learning objectives for this presentation. By the end of it, you will be able to describe the role of a voluntary isolation center in a COVID-19 public health response, describe the uptake and impact of a voluntary isolation center in reducing secondary COVID-19 household transmission in Toronto, and discuss how the use of a voluntary isolation centers could be applied in future responses to diseases of public health significance, particularly those with high likelihood of household transmission and high severity of disease. Kevin and I will be sharing with you evidence for a voluntary isolation center, an overview of the Toronto Voluntary Isolation Centre, also known as the TVIC, and its process evaluation report. We will then share information on the outcome evaluation that was written in the manuscript, specifically focusing on the evaluation questions, objectives, methods, and results. We will end with a few limitations, discussions, and implications. But before we begin, I want to briefly highlight a couple important milestones surrounding our evaluation study period to remind you of what was happening at the time. Our evaluation study period was between September 12th, 2020 and March 15th, 2021. So by September of 2020, Toronto had been notified of its first case of COVID-19. A pandemic was declared by the World Health Organization. An emergency was declared by the Government of Ontario, and a self-isolation class order was issued by Toronto Public Health. So that on September 12th, 2020, Toronto Public Health opened its voluntary isolation center. On December 15th, 2020, COVID-19 vaccines became available to vulnerable seniors and healthcare workers and it was rolled out in phases to various populations after that. The general availability of the vaccine to all non-healthcare worker public took place on April 2nd, 2021. So during our evaluation study period, a person with COVID-19 was required to self-isolate to prevent transmission of COVID-19 in the home and community. In most jurisdictions, self-isolation guidance for identified cases from the early phases of the pandemic called for prompt isolation 10 to 14 days at a time of symptom onset or a positive test. The ability to effectively self-isolate was complicated for multi-generational households, larger households, and crowded households without a sufficient number of rooms. Given the diversity of living arrangements in Toronto, safe isolation was not always possible. Between December 2019 and April 2020, 17% of household contacts of cases acquired PCR-confirmed COVID-19 infection. A global estimate of household attack rates in this period from July 2020 through March 2021 was even higher, and that was likely due to the emergence of more transmissible COVID-19 variants. In the early phases of the COVID-19 pandemic, isolation centers were thought to provide people with a safe place or safe space to voluntarily isolate until no longer considered infectious. These centers could reduce transmission and reserve health facility resources for more seriously ill patients. Beyond public health advice to test, self-isolate, and mask, few evidence-based supports were available to reduce transmission within households prior to the general availability of vaccines in 2021. Many isolation centers were extensively used and funded in places like Canada, the United States, and across Europe and Asia, and they were employed for travelers returning from abroad. Few studies empirically examined the effectiveness of voluntary isolation centers in the prevention of COVID-19. A Cochrane review on the use of the quarantine for control of COVID failed to identify any randomized studies and only identified 4 observational studies, all of which lacked a control group. A more recent study from Barcelona, Spain, compared 44 households that used an isolation center to 45 households that did not, and it found a 67% increase in odds of secondary transmission when first cases were isolated at home compared with the isolation center. This study, however, had wide error bounds that included the possible of no effect. Before vaccination, key public health strategies for responding to the COVID-19 pandemic were testing, contact tracing, and follow-up and isolation. Funded by the Public Health Agency of Canada, the TVIC opened on September 12, 2020. It was designed for Toronto residents with COVID-19, close household contacts of individuals who had COVID-19, and close non-household contacts of individuals with COVID-19 who were unable to effectively self-isolate at home. The goals of the TVIC were to decrease household COVID-19 transmission and provide a safe isolation space for Toronto residents who were unable to effectively self-isolate at home. If you stayed at the TVIC, you were provided with temporary accommodation and support like free transportation before and after your stay, a clean private room, and 3 meals a day. Toronto Public Health provided case management on site, which included connecting daily with those staying at the TVIC. There were 3 ways in which you could be referred to the TVIC. First, a Toronto Health Communicable Disease Investigator referred guests through case and contact processes. Second, individuals referred themselves by calling the COVID-19 hotline. And third, service providers referred individuals through the TVIC operation managers. During our evaluation study period, potential TVIC guests had to meet the following eligibility criteria to be admitted to the TVIC. So they had to have a COVID-19 diagnosis within 5 days of symptom onset or test date, a household contact of someone with COVID-19, and again, within 5 days of symptom onset. They had to be over 18 years of age, a non-smoker, or able to isolate during the time without smoke breaks, no existing acute or chronic health condition requiring ongoing medical care. They could not require hospitalization for COVID-19. They're not a sole care provider for a household member, and they could commit to the full isolation period. Following this evaluation study period, the TVIC actually adapted their eligibility criteria to protect those with higher risk for exposure to COVID-19, so like parents and their children, and to also allow for exceptions to the eligibility criteria by recognizing the existence of extenuating circumstances. There were two evaluations conducted on the TVIC. The first was a process evaluation completed in 2021, and the second was an outcome evaluation completed in 2024. In August 2020, Toronto Public Health and Public Health Ontario partnered to conduct a process evaluation on the TVIC for Toronto Public Health. A developmental evaluation approach allowed us to use the rigor of evaluation while allowing for flexibility in a complex, uncertain, and changing environment. Data were collected between September 2020 and March 2021 from multiple sources. And this internal report concluded that TVIC did provide a safe isolation space for Toronto residents who were unable to effectively self-isolate at home. One recommendation from the internal report was to conduct an outcome evaluation on the TVIC. Kevin will now speak about the TVIC outcome evaluation showcased in our manuscript.
Thanks for that, Jocelyn. So my role was to help with particularly with the outcome evaluation portion, and so I'll present that piece right now. And this is how Public Health Ontario teamed with Toronto Public Health in this stage. So we wanted to ask whether TVIC was effective in preventing household transmission of COVID-19. And we did that by conducting sorry, I'm having problems just changing slides. Maybe, okay, I think it's just that there's a substantial lag. Okay, so we did that by examining households that use the TVIC, and we matched them to households that did not use the TVIC, where first COVID-19 cases did not use the Toronto Voluntary Isolation Centre. And then we followed those households for a period of 28 days after the first case was admitted to the TVIC. And so we did this using propensity score matching was the method we used for specifically matching households. We included cases between September and March 2021. As you saw from Jocelyn's introduction, the vaccine was generally available in April 2021 to the population. So we stopped because we were interested in the effectiveness of the intervention before rollout of vaccine. And we matched each household that used the TVIC to 10 households that self-isolated. We used 3 different data sources, the case and contact management system. We extracted neighborhood characteristics from the census, and we also used the line list for the Toronto Voluntary Isolation Centre. Next slide, please. Next slide, please. Jocelyn, would you be able to move my slide forward, please? Thank you.
Yep. Yeah. Kevin, which slide would you like to be on?
22, please.
Okay, thank you.
Actually, no, this is the slide. Sorry, it's a little bit laggy. So yeah, so at this point we used 10-to-1 matching, and the variables that we matched on were age, gender, specimen collection delay, the household size, the calendar date, the size of the outbreak, household crowding, low income and visible minority status. Those latter three variables were coming from the census, whereas all the other variables came from the public health line list data. And the outcome we were looking at was the secondary attack rate within the household. So that was all the cases that occurred within the household, measured as a proportion of the actual people living there. And then we used a statistical analysis called a proportional hazards model to measure those outcomes, comparing households that used the TVIC and households that didn't. For the matched households, we actually matched them and only started follow-up on the day that the matched household had actually entered into TVIC. So we were only capturing the portion of the household follow-up that was eligible to be that was able to be impacted by the intervention. Yeah, so we started off, so this is a diagram that indicates how households were included in the study design. So we started with a line list from Toronto Public Health that had 768 individuals that were referred or assessed for TVIC in the time period. Some of those didn't accept the offer and didn't check into the TVIC. And then some didn't link to the provincial line list. And then so we ended up with about 516 individuals that were admitted to TVIC, of whom they came from around 410 different households. And then some of those individuals weren't the first case ever admitted with COVID-19 that were admitted to those households. So those households were also excluded. So we ended up with 304 households that we identified as having used, where the first case used TVIC. And of those 303 were matched with 2,943 households that did not use TVIC. Within those 303 households, there were 1,015 individuals that were at risk. So around 3 individuals per household were still at risk of developing COVID-19 at the beginning of the follow-up period. Next slide, please. So prior to matching, the households were quite different. We could see that in the period prior to matching, the age of households was quite a bit younger in TVIC households, or the age of first cases, more likely to be male, and quite a bit shorter time to specimen collection delay. So that means from the symptom onset to when they got their COVID-19 sample collected. After matching, those differences weren't significant anymore or substantial. There were these 303 TVIC households that were matched to 2,900 self-isolation households, and uptake was estimated to be around 1% of households when we examined that. So what we saw was that this slide shows the cumulative household secondary attack rate on the y-axis, and on the x, so horizontally, you see the follow-up time. So that starts at time 0 and for 28 days subsequently. The red line depicts the cumulative number or proportion of the household infected in households that didn't use the Toronto Voluntary Isolation Centre, so self-isolation households, and the blue line represents the households that self-isolated. So what you can see is that there was around in self-isolation households, around 8.4% of household members were infected after an index case or after a first case developed COVID-19. And in the self-isolation, in the TVIC households, that proportion was around 5.2%. So there was around a 38% reduction in the risk. On the hazard ratio scale, this translated to a 50% reduction in risk of COVID-19 in those TVIC households compared to the self-isolation households. We also broke things down across strata. So what we saw when households, when that first case was admitted very rapidly after their symptom onset to the voluntary isolation center. So if that happened within 2 days, what we saw was a larger benefit actually of the intervention. So the top panel represents those households where first cases were admitted rapidly, the blue line on that top panel. And when they were compared, you saw a substantially larger reduction in secondary transmission of COVID-19 in those households. And when the delay was longer, when the delay was greater than 3 days, we saw that the benefit of the intervention was smaller. We did a number of other stratified analyses like this. So we also looked at a number of different household factors. So we looked at, neighborhood factors. We looked at neighborhoods where household crowding was higher. And we saw, and this is based on the Statistics Canada definition of household crowding. So that's a definition where it means that adults that are not in a relationship are sharing bedrooms. So it's quite a stringent standard. So we saw a larger benefit, so a smaller hazard ratio in those neighborhoods. We saw a smaller hazard ratio in low-income neighborhoods, and we saw a larger benefit or a smaller hazard ratio also in neighborhoods with higher proportions of visible minority individuals. Next slide, please. So just to summarize, what we saw was a secondary attack rate of 5.2% in households that where first cases used the TVIC compared to 8.4% in matched self-isolation households. And that was estimated to be a 50% reduction in the hazard ratio of COVID-19. And I'll pass it on to my colleague, Jocelyn, to talk about limitations and implications of the study. Thank you.
Great, thanks, Kevin. The study was subjected to a few limitations. Our outcomes were based on laboratory confirmed COVID-19 infections from Ontario's COVID-19 registry. Provincial guidance during this period recommended testing of all symptomatic cases and asymptomatic contacts of cases. However, some infections, particularly those with mild symptoms, could have been missed if they did not present for testing. The TVIC user could have been different than those who did not use the TVIC in ways not captured by the included covariates. For example, those households that use the TVIC could have been especially crowded or have been overrepresented with vaccine-eligible healthcare workers or older, and immunocompromised individuals. Some secondary cases that occurred in the follow-up period may have already been infected and unable to benefit from the intervention. To this, a sensitivity analysis using a more specific follow-up period of 3 to 21 days post-TVIC check-in suggested a larger estimated effectiveness. We were unable to capture transmission outside of the household, for example, say from grocery shopping, but on the other hand, no transmissions at the TVIC were documented or suspected. From our results, we found that voluntary isolation or voluntary hotel-based isolation could be an option for diseases with high likelihood of household transmission, high severity of disease prior to the availability of vaccines. There were consistent associations across subgroups for the reduction in COVID-19 transmission in households when first cases used the TVIC compared to matched households where first cases self-isolated. This association was generally consistent between many subgroups, suggesting a broad benefit from using a voluntary isolation center. To be more effective, voluntary isolation must occur early in the period of transmissibility. Oh my goodness, transmissibility. Sorry. Households where index cases or first cases were admitted to the TVIC within 2 days of symptom onset had greater reductions in household transmission. This result aligns with literature of COVID-19 shedding period. Which suggests viral load peaks near the date of symptom onset and is generally undetectable by PCR at 10 days after symptom onset. We also need to build guidelines for rapidly scaling up voluntary isolation into future pandemic preparedness plans. This may include the number, location, types of sites, funding, and occupancy management. This expansion of access to voluntary isolation centers should likely take place alongside broader strengthening of self-isolation guidance, support, and follow-up. The self-isolation support system could consider triage questionnaires that systematically assess the ability of cases to self-isolate at home, like household crowding, availability of spaces to isolate, presence of dependents, as well as assess the morbidity risk factors of household members, like age and immunocompromising conditions. All right, conclusion. In conclusion, the TVIC use was associated with a 50% reduction in secondary transmission of COVID-19 in households prior to the availability of vaccines. Voluntary isolation centers may help individuals to isolate effectively, particularly when check-in occurs promptly after symptom onset. Results from this outcome evaluation suggest that certain subgroups of households may benefit more, particularly larger and more crowded households. Lastly, these results can be used by public health leaders to inform future use of voluntary isolation centers as one public health tool to effectively control future communicable infections and pandemic pathogens, particularly those with an important household transmission component. Here is the list of references for the presentation. Oh, there we go, page number 2. And lastly, thank you for having us today to share our project work on the effectiveness of the TVIC in reducing household secondary transmission of COVID-19. For more information about this presentation and our published manuscript, please contact Kevin or me. And I now invite the moderator to continue from here.
Thank you so much, both Jocelyn and Kevin, for your really informative presentations today. Really interesting to learn about both the process and the outcome evaluations, which is really wonderful to see in terms of generating lessons learned. So we are now moving into the question and answer period. I see we've already got at least one question in the Q&A pod. Now is a great time to share your question. If you are considering a question, likely others are too, so please do share, and we'll bring these forward to our speakers today to try to share further insights. So again, it's the Q&A pod, and I will start with the first question that has come in. The first question is, in the context of all of this data, what would have been the effect given the 50%, and I think this is referring to the hazard ratio reduction in secondary infections? In Ontario, how many secondary infections occurred? So I think maybe, Kevin, this is a question I'll hand to you first, and I think this is about sort of giving some absolute context around the potential effect more broadly of use of TVICs?
It's a good question, one that we don't necessarily have the answer to right in front of us, but one can imagine that the households that used the TVIC were, particularly suited to benefit from it, right? Households where individuals lived alone wouldn't have been eligible to use it, and a substantial number of people in Ontario live alone. But so one can imagine if you rolled this out, you'd get a reduction in incidence that was somewhat less than 50%. On the plus side, there are, in general, with any infectious disease intervention, potentially some synergistic effects, which would actually kind of increase the effectiveness of the intervention. So we don't have a direct answer to that question, but there's reasons to believe it would be quite effective at reducing transmission.
Thank you. And do you have anything to add, Jocelyn, to that? Okay, wonderful. Thank you, Kevin. So we have another question. And this was about the supports in place in TVIC. So if a person staying in the voluntary isolation center needed a medical assessment for worsening illness, how was this arranged? And I note that one of the eligibility criteria was not requiring hospital care. So interested in how you navigated that in practice. Maybe Jocelyn, you could perhaps respond first.
Yes, that's correct. I know, as you mentioned, Leanne, that if somebody required hospitalization, they were ineligible for being transferred to the TVIC, as they had to stay for, again, voluntarily stay for the entire time at the TVIC. And so if they were unable to, they had to still continue to isolate somewhere else. So if they didn't stay at the TVIC, they could go home and have to still self-isolate there, which is not always possible. But if their symptoms did get worse, they would be and if they were staying at the TVIC, they would be transferred to the hospital if necessary and continued from there to get care.
Thank you so much, Jocelyn. I'm going to go to another implementation question, which is about the voluntary nature of the sites and how you navigated that. So were participants at the TVIC allowed to leave the center while they were infectious? And if yes, was there a way to tell if they did not return to their home? Good question.
Oh, very good question.
Mm-hmm.
So I do know that, again, it was a voluntary isolation center. So if someone wanted to leave the voluntary isolation center, they could, but they were told that, they had to continue their self-isolation at home. And that it was kind of a mandated thing that they had to follow because at the time that was the rules of the government and within Toronto as well. I don't know if anybody did go home and how we would have personally tracked them at home for TPH and whether or not they would still receive their case and contact kind of management from their home from the TVIC, or whether that would be transferred to somebody else. Now, as the time went on, at the beginning of TVIC, you weren't allowed to leave your room. So you had to stay within a hotel room for the entire time of your infectious period. So depending on when you came into the TVIC, that could be a long period of time for people. But as time went over, and again, thankfully, with many check-ins, daily check-ins with residents, guests who stayed there, we did end up allowing people to take breaks outside. It was very important to get some fresh air. And so certain practices were protocols were put into place in order to escort people outside so they could have some fresh air breaks as well, because staying within a hotel room with no windows that open can be very difficult for multiple days at a time. Although guests were still provided with other ways to communicate with the outside world, it's not the same as getting some fresh air. So we did end up modifying our protocols to accommodate this.
Thanks so much. So another question for Kevin Brown. Would you expect to see similar results if this study was done during more transmissible SARS-CoV-2 strains or variants versus lower transmissibility? So acknowledging the evolution of the transmissibility of the virus itself over time.
I think we would expect it to be as effective with a more or less transmissible strain. It depends somewhat. What would make a difference would be the period of transmissibility relative to symptom onset, and we saw some shifts from variant to variant with that. But most of these emerging VO variants of concern, as they were called at the time, were occurred after the period that that we ended this intervention. But we would expect to see very similar effectiveness. But what makes a difference would have been, obviously the vaccination and the specific period of transmissibility relative to symptom onset. So any infection that is where a greater portion of the period of transmissibility is prior to recognition of symptoms would be an intervention like this would be less effective.
Thank you. I will take the moderator's privilege to perhaps ask Jocelyn a couple of questions that rose for me in respect of the process evaluation. So you spoke about sort of evolving approaches or eligibility criteria over the study period and over the implementation period. I'm wondering if you could just speak to the process of that. Like how were the criteria reassessed? What was your approach to meeting evolving needs or addressing client needs over time? And in particular, I was interested in the approach to supporting families that you mentioned very briefly, if you could speak a little bit further to that.
Right. So I'll go based on the conversations I had with the TVIC managers and what they told me about what they did. I wasn't part of the direct implementation of the program at the hotel either. So just to put that disclaimer out there as well. That yes. So when the TVIC first started, there were documents and protocols put into place, heavily focused on IPAC protocols so that everybody going into the TVIC, whether you're a worker or a client, could feel safe. And at that time, there was a 6 feet rule. You know, we had certain floors that were for the cases, and we had certain floors in the hotel that were for the contacts. So again, there wasn't any overlapping or potential risk of transmission within the hotel itself. But based on, again, at the beginning of the pilot project as well, you know, there was guests that were in every other room. And so over time, again, from one perspective, you might think, oh, why is it every other room? But, you know, that was kind of the IPAC kind of protocols at the time. And so again, we were bringing in more people to be able to stay in the TVIC after we kind of saw again that they were able to accommodate more people, able to follow the rules properly according to the guidelines. And so that was great. But again, when you have a rigid kind of eligibility, because at first we didn't quite know how many people would be coming, and we were worried about being over and inundated and everybody wanting this, you know, to use our service, we realized that we could actually take on more people. And so I think that's when we started expanding the eligibility criteria. And also through conversations with our communicable disease investigators who were trying at the time to decide, do I recommend them to go to TVIC? Oh, they might have most of these, or maybe they have, like, they can't really leave because they are the care provider, or with the young children, or maybe they're already infected, or we don't know. So there's a lot of circumstances where they weren't quite sure how to advise their client about how to move forward and whether or not the TVIC would be right for them. So again, based on these kind of conversations we're having with the CDIs or the communicable disease investigators, depending on the capacity within the hotel as well, we are able to take on more people who might not have been considered eligible according to the original eligibility criteria. So I think through the process evaluation, but also just as, like I said, it was a developmental evaluation because the program was kind of developing as we were going along, we were able to adjust the eligibility criteria. And as I mentioned, another example was that we were able to take in families and also to go out for fresh air breaks, which became very evident as important as somebody for staying at the TVIC. Sorry, that was very long-winded. I hope that's okay.
No, thank you so much. Thank you so much for sharing those insights. Kevin, I have a sort of reflective question for you on the outcome evaluation sort of process, and in particular, how the process evaluation in your eyes informed the design of the outcome evaluation. And then part B of my question is, how did that collaboration between the local public health unit, Toronto Public Health, and PHO, you know, support, I guess, the work you were able to accomplish? What what uh, what local perspectives, I guess, were in your view key to informing the study that you were able to complete and publish? So congratulations on that as well.
I think it was really, you know, Rachel Laxer's kind of initiative that had, started that whole process. And when I had learned about the existence of the process evaluation, that initial process evaluation that had occurred, I think it kind of opened the door to seeing what was, I guess, what was possible, existence of, a systematic examination and review of, uh, of the whole evaluation process from, from how people were being admitted, um, that whole, that whole process was in place already. So I think it was kind of, I think that opened the door basically is how I would say, and opened the door to both the collaboration as well as the study itself. And then having, it was neat, and I'm not that familiar with other circumstances in which kind of the routine um, uh, case contact management system was used in combination with the local kind of process measures to create this kind of evaluation. So that was, that there was a piece that was the facilitation through the process evaluation, but then Ontario also had a pretty rigorous data collection process for uh, uh, case and contact management that made it all possible when it was all put together. So it was really trying to harness those two sides, um, the local data as well as the provincial data.
And I think just to jump in that, the process evaluation that we conducted was great for Toronto Public Health because we needed to know how it went. And this was something kind of new to us. We'd never done anything like it before. And, we were able to work with Public Health Ontario to kind of have a focus, couple of people working on it as we were attending to the other things that were happening during this very, very busy time of year and time, I'm sorry, during the pandemic. So we were very thankful to have a partnership with Public Health Ontario at the time. And again, it seemed like a seamless continuation of our work because we were able to determine that, yes, we could provide a safe space for people with COVID at this voluntary isolation center. But we really wanted to know, well, how well did we really do and how effective was our center for reducing the household transmission. So once again, no brainer to work with Public Health Ontario and Kevin to kind of in his team, like I said before, we had a wealth of people and information and expertise who were able to contribute to our manuscript and this evaluation to actually be able to determine this. And thankfully, data was collected on our end at Toronto Public Health and also data provided through the CCM registry, so that was fantastic that we were able to access that.
Thanks for those reflections. I did have a couple more questions, so I would just say this is a last call for questions in the Q&A. We do still have a few more minutes, and so if you do have a question, please share it. A question for both of you, just in terms of placing your studies findings, both your process and your outcome evaluation work in the context of other literature that's emerged from the pandemic. Did other jurisdictions attempt the same types of evaluations for similar facilities, and how do you see your findings either fitting or not fitting within that body of literature?
First, or should I take a stab at it,
Well,
Jocelyn?
I was just, I know that of other isolation centers that were happening in other areas within Ontario. So again, with COVID-19, people, we directed them to if you're a Toronto resident, to come to the Toronto Voluntary Isolation Centre. But I do know there were some other isolation centers, depending on your criteria or eligibility. You could go to Peel. I think Durham had one. There was an Ottawa. So, I know of other places that were doing voluntary isolation centers. However, I don't know of any others that have done an evaluation on the process or the outcome of the use of these centers. So maybe that's why I'll pass it over to Kevin to see what he knows.
Yeah, I think Jocelyn touched on it a little bit. There's really very little evidence around use of voluntary isolation centers. I think I have a little bit of difficulty understanding why that is. I think the part of it may be that it's such an obvious intervention. Why does it need to be evaluated? And I think one of the reasons why it needs to be evaluated is because we need to know how to optimize it. We need to know what the time thresholds are. We need to know, you know, when you roll this out, are we getting people into these isolation centers early enough to actually make a difference? I think that's probably the main, the one of the main questions. And we really saw that the earlier we were able to get people to check in, and we were able to do that in a substantial portion of cases, the more effective the intervention was. But to be honest, there aren't a lot of studies. There's that one study that had something like 40 households. So this study was about 10 times larger than that prior study. But compared to other effective interventions like vaccination, this is like very much understudied. And surprisingly, like one of the few non-pharmaceutical interventions that was really effective at preventing transmission within the household, because there's a lot of non-pharmaceutical interventions that were rolled out to prevent a transmission in the population outside of the household, but very little that was actually specifically designed to prevent household transmission, and such a large portion of transmission occurs in the household, right? So that's I don't have a much better answer than that. It maybe yeah.
Well, I think that that is a fitting note to end on, just in terms of recognizing the value of the work that you both shared in terms of uh, the rigorous process and outcome evaluations that were conducted and that have been able to be then shared more broadly. So thank you so much for wonderful presentations and valuable discussion today. I can see my capacity building colleagues have already shared a link to an evaluation. So as we wrap up, please do share your feedback with us via the brief and anonymous survey or evaluation. For today's session, we do use this to help improve our programming. A huge thank you to Jocelyn Edwards and Dr. Kevin Brown, our presenters for today. Thank you to everyone who shared their time with us and offered up questions. And finally, a reminder that tomorrow is the virtual Ontario Public Health Convention. You can check it out if you're still interested at www.tophc.ca. Thank you so much again to our presenters, to everyone who joined us. Have a wonderful afternoon.